PHC is for my friend Massimo Colombo. There is so much to say about Massimo, but you all know that his main interest is diagnosis and treatment of viral hepatitis and liver cancer, obviously. And Massimo Colombo has now a position of professor of medicine and gastroenterology at the university for more than 25 years. He was chairman of the division of gastroenterology and other specialties, big department, and now he's the director of the Center for Translational Research in Liver Disease at Humanitas Research Hospital, Rossano, Italy. He had many awards, especially we can see he had award from EASL, Distinguished Award. He had a recognition award. He had also awards from Italy, Germany, and from the Liver International Cancer. He made a big job for Journal of Hepatology. He was editor-in-chief of Journal of Hepatology from 2005 to 2009, and then worked again for a long time for the journal and other important journals. A long career of editorial. He was the chair of writing committees for EASL clinical practice, and also what is very important, I think, this project is crucial for the future of hepatology, of European hepatology. He was appointed as the chairman of EASL International Liver Foundation, and he's working hard to expand education and optimize management of patients in other countries and continents, Asia and Africa. He published so much. I don't know if, Massimo, you can sleep or have some weekends. I hope so. And he's not only a researcher and a clinician, he loves animals, you can see. He is a sportsman. I don't know, Massimo, you are on a boat? Where you are? No? You're on the beach? Yeah. Okay. And he's also an archaeologist. Research has no frontiers. And, but he knows also, he likes also the Arabian culture, different cultures, as you see, around the table. Not many ladies on this photo, I think. He likes Asia. You are not Buddhist, Massimo, no. You look like a Buddhist. And he likes Paris. That's why he comes every year since 2004, every PHC. That's always a pleasure. And we can see Massimo and Paola. She speaks a very good French, so I can speak Italian, and Massimo speaks English, and Paola speaks French. And so, Massimo, this is really a pleasure. Massimo is a great friend, and he is a gentleman. I think, Massimo, you represent la grandeur italienne. Massimo, I give you the word. Thank you.
Good afternoon. Many thanks, Patrick. Many thanks to all of you. I'm really happy to be here with you, and I was given the task of such a presentation, which is a little bit ambitious. I hope to fulfill your expectation. Let's start here. Okay. Hepatocellular carcinoma today and the future. And I would say in the future, I will try just to reproduce a little bit what is the official position of the European Association for the Study of the Liver, not to flying around with funny ideas. These are my conflicts. And let me start just depicting the current situation of epidemiology, because this, unfortunately, I believe, is the bad news regarding hepatocellular carcinoma today. Liver cancer, in fact, is a big problem. If you read here, 16 leading cause of death globally means little, but it's the second cause of cancer death in men and the sixth in women. And currently, the incidence rate are more than double in the last 2 decades, 1 million of incident cases causing more than 100,000 deaths per year. This is the consequence of an increase in size and in aging of the worldwide population, and as you see here. And this is to some extent caused by an inflation of a certain, let's say, subclasses of liver cancer, particularly hepatitis C and, as we heard, metabolic syndrome-related cancer, despite the fact that the hepatitis B virus is the leading risk factor for liver cancer. More than 180 million people live with chronic hepatitis B, and there is more than 500,000 of liver cancer that are related to chronic infection with these viruses. What is really worrisome is the fact that in the so-called high socio-demographic index countries, Northern Europe and North America, the tumor is on the rise. And this is a little bit surprising, because if you look at the map of the incidence rate of this cancer, you would predict that this tumor is growing in those traditionally high-risk areas like the Far East or Africa. No, that's not true. The reddish area here depicts the situation where in northern of Europe and in North America, the tumor is on the rise. You see EAPC, mean estimated annual percentage changes. And this has been clearly related in part to the epidemic of NAFLD, but if you look more closely to the data that are going to be published in the Journal of Hepatology here, where actually the incidence rate of the cancer has been stratified by etiology, LCHB means hepatitis B-related liver cancer, you might appreciate that there is a steady increase in the risk of liver cancer related to hepatitis B right in the high middle social demographic index countries, those, in other words, with the high-income countries. And these appear to be related to an epidemic of viral hepatitis spread around by risk factors, or if you wish, parental risk behaviors. And this turns into a new recommendation for those countries to a little bit fine-tuning their current strategies for primary prevention of liver cancer. They should start delivering vaccination against hepatitis B, not only to the newborns, but also to the adolescents, like Italy did. While doing so, in Italy, we got rid of the fulminant cases of hepatitis delta spread by sexual behavior and parental risk factors. While in the high-income countries, we are facing this threat of a growing epidemic of liver cancer, at the same time, we are enjoying important step forwards in the management of those patients who already have liver cancer. And we must attribute this to the hard work done in Barcelona by a group of oncohepatologists led by Professor Jordi Bruix, who depicted the natural history of the disease and allowed for the generation of an algorithm that proved to be effective in stratifying patients to receive the correct treatment modality. And you know, now we enjoy an algorithm whereby your patient with liver cancer might flow through different stages of the disease, the so-called sequential concept. And this is a situation whereby patients might start having an early detected cancer, perhaps in the high-income regions through screening, and might enjoy potentially curative therapies like resection, transplantation, or local ablation. But if the tumor proceeds to remain confined to the liver, but expanding in volume, the so-called intermediate stage, chemoembolization proved to be effective, and you see also the survival benefit associated with this procedure. And when the tumor further grows, today we have 2 first-line therapy for this so-called advanced liver cancer. There are TKI, sorafenib and lenvatinib, although many experts think that we still need to gather more robust data regarding the safety and efficacy in lenvatinib, that so far we dispose only of data stemming from registration trials. And when the patients fail to respond the first line, today we have a number of options available, TKI and monoclonal antibodies, and this is the first time that in the liver domain we have an option that is selectively fitting the, this is selectively deliverable to patients with a biomarker, more than 100 nanograms of alpha-fetoprotein. But in America, Food and Drug Administration recently registered nivolumab, an immune checkpoint inhibitor, as a second-line therapy based on the preliminary result of a phase 1/2 study for patients failing to respond or unfit to be treated in this way. It must be outlined, however, that this algorithm that has been created on the basis of evidence-based data that allow to stratify patients to receive the best therapeutic options can only fit 70% of our population real life. There is still 30% of our patients do not fit exactly into this, and they might move backward compared to what I show you, or they have to be treated in something that in first glance appears to be inappropriate. You might have a patient with a small tumor in the liver that cannot fit criteria for transplantation, ablation, or resection, then move forward to receive a less effective regimen, palliative therapy. That said, I wish to spend just 2 words on nivolumab and the likes, because this is the real breakthrough coming to benefit patients with advanced liver cancer. You know, the gold rush of cancer immunotherapy trials, more than 1,000 trials going forward to test these magic molecules that can be approximately divided into 2 broad categories. One category are the direct stimulating agent that try to wake up the sleeping T cells, and the other molecules are those considered to be selective inhibitor agent that can inhibit a specific interaction between the T cells and the antigen-presenting cell, or the T cell and cancer cell. The very first of such inhibitory agent to be registered was an inhibitor ipilimumab that inhibit the CTLA-4 molecule and proved to offer important survival benefits to patients with advanced melanoma and other on the line. Now, the good things here is that these drugs can be offered as a monotherapy, but more recently we have surfacing data that show that combination of various molecules is delivering more effective survival benefits to our patients. And to tell you, to give you just a flavor of what I'm saying, look at the data regarding the CheckMate study, which helped to register in America nivolumab for sorafenib-experienced population. In this sorafenib-naive population, you may achieve up to 29 months of survival, with having 57% of the population alive after 1.5 years of enrollment. And in this sorafenib-experienced population, you might get 16 months survival, with 46% of the population alive 1.5 years after enrolling. And if you compare this survival with the survival of the placebo-treated patients in the resource trial, meaning those patients who were sorafenib experienced and were not randomized to receive regorafenib, where your survival was predictably in the range of 8 months, those randomized to receive nivolumab had a more than double survival probability. So quite enthusiastic. But I would say these are the good news in the area of the advanced cancer. But there are also good news coming through in the opposite wing of the population, those with an early cancer, and I'm referring to liver transplantation. Why? Because in the very last 2 or 3 years, listing for clinical decompensation is declining everywhere in the world, and there is more room available to treat patients with liver cancer using transplantation. Transplantation, of course, cannot be offered to everyone. Only 5% of the patients with liver cancer worldwide are receiving liver transplantation, well-selected population, of course, and the reason is quite obvious to you. There is scarce donations going around. But since that, with the decline of liver decompensation in the list to liver transplantation, more options are available for patients with cancer. And so we wish to, many centers have adopted alternative criteria to select patients for listing always trying to respect the paradigm of utility. Preventing what? Preventing cancer recurrence, which is the real killer in patients who receive a liver transplantation for liver cancer. So moving out of the so-called Milan criteria that represent a very cost-effective approach to treat patients with early detected liver cancer, which is confined to the liver and other peculiarities, of course. And the reason why experts wish to go beyond Milan criteria is because patients who do not fit with these metrics are being offered palliative therapies that, of course, do not translate in long survival. There are studies done in San Francisco or in Milan itself, Mazzaferro, or combining the metrics of tumor burden with the biological markers like alpha-fetoprotein here and there, to try to optimize selection of patients respecting the paradigm of utility, preventing recurrence. And we are, in fact, aware that the tumor recurrence is the real killer in patients that undergo successful liver transplantation. And the two Western societies have already outlined the criteria to define the risk of tumor recurrence. A big tumor burden diagnosed at radiology, including macrovascular invasion. Histology, which might be helpful only if you are bridging your patient or you're downstaging your patient with resection, but if you don't, that is not helping at all. Or, most important of everything, is downstaging, meaning bringing the burden of the tumor within the domain of Milan criteria and then transplant your patient. But here, you know, things are not that easy because there is no standardized criteria in terms of time lag between downstaging and listing and transplant delivery. And there are no standardized criteria to define downstaging. The vast majority of centers define downstaging as a return within Milan criteria. Other centers prefer to define it as a disappearance of any viable tumor cells at radiology. So with all these caveats, methodological caveats, still downstaging stands as the only pragmatical approach to bring to liver transplantation a patients that present outside Milan criteria. And this has been taken up by the Western societies, EASL and SLD, and in their recommendation, they claim that patients outside Milan can be considered for liver transplantation after successful downstaging to within Milan criteria. Both America and Europe speak the same language here. And these are decisions were made based on a couple of studies that were, in my opinion, very convincing. Professor Alazon is a fine surgeon in New York, did such a retrospective study, taking advantage of a situation in America. In America, there are many transplant centers that are long waiting before transplanting their selected population, whereas there are centers that are quite quick, rapid in transplanting their patient. If you take this population, which is a mix of within Milan and outside Milan criteria, the so-called T3, that, however, have been downstaged successfully, you can clearly appreciate in this study that the downstage population that was transplanted in centers with a long waiting time period, in terms of intention to treat analysis, survived longer than the same population that was treated in short waiting centers. And this notwithstanding the fact that, of course, in the long waiting centers, there were higher rates of dropout and mortality during waiting. But intention to treat analysis, you know, get rid of these discrepancies. And the second paper that I wish to show you that emphasized the importance of alpha-fetoprotein as a potential biomarker to improve selection of patients to be transplanted is this one done at UCLA by the group of Professor Busuti. In brief, 1 out of 3 patients with the liver cancer that are approaching a transplantation center do not secrete more than 10 nanograms of alpha-fetoprotein, so alpha-fetoprotein negative. The rest 2/3 have higher levels. Patients with normal alpha-fetoprotein survive longer after transplantation than patients with high alpha-fetoproteins. However, if you downstage your patients within Milan criteria and you can bring alpha-fetoprotein down equal or less than 10 nanograms, you have another green light. and the survival is as good as that of patients with normal or negative, if you wish, alpha-fetoprotein. And of course, the same is true if you take into consideration recurrence rate, which is specular to the rate of survival. So Professor Marcelin told me, you must say something about the future direction. Okay, I mean, I'm not in a position to do this, and I just copy what the European Association for the Study of the Liver is recommending to us. This is a panel of distinguished hepatologists led by Professor Peter Galler, Mainz, who sits here, including fantastic transplanter like Mazzaferro, scientist, fantastic radiology as Valérie Vilgren, hepatologist, oncologist from Barcelona like Forner, I mean, and then Professor Raoul from Paris. And what they say, they claim that we should implement public health policies to prevent, detect, and treat chronic liver disease in the future. I like this, but there is a problem. How to detect patients with chronic liver disease, because we do not dispose of biomarkers that are accurate enough to do this. And then we heard a lot about criteria to prevent metabolic-related liver disease or alcohol abuse. I mean, wishful thinking in many instances. We better stick with the pragmatic consideration. Viral hepatitis B plus viral hepatitis C make the large burden of liver cancer currently. And look what happened when we try to curb the risk of developing cancer in this population. This is something that has been published by WHO and it provides you with an important message. Unfortunately, the rate of diagnosed patients with Hep B, Hep C is lower than expected. You know, the brown is what we are now, and the yellow is what we are predicted to achieve by 2030 when WHO predicts elimination of viral hepatitis on a worldwide basis. Okay, with this as a background, you're not surprised to find that also the rate of patients undergoing hepatitis B and hepatitis therapy is tiny, compared to what we have successfully achieved in the field of hepatitis B vaccination or providing blood safety or injection safety. So we lag behind. But if you stick to viral hepatitis, which is something that pragmatically needs to be taken into account, here we are moving ahead. Take China. I like China, because if you look at Taiwan, they have big data coming from this national viral hepatitis program. You know, they have undergone changes over the past 15 years in the criteria of selecting patients to therapy, in providing and covering the insurance here and there. But Taiwan is perfect because all the population is captured by their registry system. And here you see that moving from 2003 to now, these 2 periods of 3 years each, there has been a decline in men and women in the rate of hepatocellular carcinoma incidence and mortality, and this is considered to be significant. And we are talking about 150,000 population. If you move left to the mainland China, you have data regarding prevention of liver cancer following vaccination against hepatitis B. And this is something that has been done in the Qidong area, which is an hyperendemic area. And you see here, fantastic. Already in the ages of the adolescence ages and the adult ages, you might perceive the benefit of the vaccination against hepatitis B in terms of prevention of incidence of hepatocellular carcinoma. And I tell you that their incidence overlaps mortality even more frequently than does in our places. The second recommendation by ISL is that we should implement appropriate cancer surveillance to detect HCC in a stage amenable to curative treatment. This, of course, is something that can apply only to the high-income geographic areas, not to the low-income geographic areas. And we know perfectly that this is also the case for other preventive strategies, not only for liver cancer. But what happens in the high-income regions where you do expect that we follow these recommendations? Okay, the good lesson comes from Japan. Screening rose from 30% 40 years ago to almost 80% currently, and in parallel, there has been a significant increase in the overall survival from 17 to 52 months. But in other high-income areas like here, Italy, Hong Kong, and USA, we lag behind. In France, there's a tiny minority of HCC are diagnosed in the context of screening. In Hong Kong, there has not been screened until a few years ago, and the overall survival for HCC was 18 months on average. And in America, quite dated reports here, only a minority of the patient with cirrhosis uptake surveillance, and when someone, like Amit Singhan and others, scrutinize a patient with a diagnosis of HCC and look backward at 3 years preceding the diagnosis of HCC, we are talking about patients with cirrhosis, half of those with metabolic syndrome and 40% of those with alcohol were not treated with screening, whereas the vast majority of hepatitis C patients were. So there are issues here. And this explains why screening, aiming at developing early diagnosis, does not fit the purpose of eliminating liver cancer in the low-income areas, where you have the issue to identify the target with chronic liver disease, to frame it in a complex surveillance system, and then link it to care, so almost impossible. And that you must believe that is true because you learn a similar lesson from America, which is a high-income area. But you know, the real-life lesson that we got from Veteran Administration. They made a case-control study of surveillance uptake in patients with cirrhosis, and they found the same proportion of patients between patients who died of liver cancer and those who did not, implying, therefore, that making or making screening made no difference. Unfortunately, the study was flawed by some problems of methodology. There were a few ultrasound exams done in a 4-year period, whereas we are aware that screening should be done every 6 months. And although the majority of the patients were Milan in, only a tiny minority in the end underwent resection or ablation, and none underwent transplantation. So faulty screening coupled with no linkage to care. If this happens in a context where we can also think that the vast majority of these patients had severe comorbidity that prevented the listing to curative therapies, you might imagine what could happen in the low-income areas like Africa, many parts of South America and Asia. And the same real-life lesson from VA tell us something better, that the primary prevention outperforms secondary prevention, because in the same domain, cultural and healthcare domain, massive access of patients to DAA translate in a higher rate of SVR with a significant decline in death rates and incidence cancer. So this is a good lesson that we should accept. In low-income areas, fighting cancer means fighting the predisposing factors and the etiologies. The last is the linked molecular subclasses in clinical trial to therapeutic response and outcome, because liver cancer has remained an old-fashioned cancer in terms of patient stratification and linkage to care. We treat patients, as we said, according to the algorithm developed in Barcelona that has been endorsed by ISOL and ASL, but we still fail to identify subclasses of patients that might take advantage by specific therapies or in which we can predict different outcomes. There has been a lot of work done here in Europe, particularly the group of Professor Jessica Zuckman-Rossi, and I urge you to read this nice review written by her, where you have here the 4 potential causative factors of chronic liver disease leading to epigenetic changes and with genomic changes at the number of mutations that translate into the risk of developing cancer. But there are important limitations in the natural history of liver cancer that prevent hepatologists and scientists to develop a new algorithm based on mutation of the genes or molecular features of the tumor. And this is the fact that the tumor is highly heterogeneous, not only in terms of risk factors, not only of biology, not only in terms of genetic mutation, but also highly heterogeneous in terms of epidemiology. And in the end, you have many mutations that cannot compose a single model to develop what we actually would like to have, a predictive biomarker to substitute the histopathological study of the liver. And Dr. Zuckman, Professor Zuckman, and her co-workers, in fact, try to make a compound analysis of about this heterogeneity of liver cancer, joining the clinical features, the genetic alteration, the molecular classification with specific pathological features that to some extent correlate with a specific biological pathway. But at this point, owing to the fact that the vast majority of these studies were carried out on biased material because just produced through resection of the tumor, and that owing to the fact that there are no common genetic mutation to be used as a predictor of subclasses, and there are no driver genes that take the lead of the development of cancer that can be used to identify a specific subset of patients to be treated with specific regimens. Currently, the future direction are to some extent like a dream. We dream to have a liquid biopsy and to substitute liver biopsy that currently the radiological techniques for diagnosis of HCC in cirrhosis have to some extent canceled. A liquid biopsy could be used for diagnosis, stratification of patients, and monitoring response to treatment. There are a few candidates: extracellular vesicle, cell-free nucleic acid, and more recently, I read a couple of papers, one interested from Boston, the epithelial tumor cells that can bring around in the blood all the genetic information, but again, there are no common mutations, there are no driver genes, so you still are quite far from having very effective tools. And of course, this would be essential to develop into a personalized medicine approach for liver cancer and use, HCC subclasses to select the optimal therapy for patients, like in other solid or liquid tumor our colleagues are doing. And of course, we wish to have something better than alpha-FIT or DCP and the likes to use as a biomarkers for identify the subset of patients with a higher rates of response to specific target therapies. When Professor Marcelen asked me to give this lecture, I was perfectly aware not to be able to discuss further in detail this difficult area because I'm not a scientist, but I did not resist the temptation to make some publicity to what the foundation is doing. Let me finish the presentation to tell you that what we are seeing here as a barrier to development of a liquid biopsy, or if you wish, as identification of biomarkers to optimize the management of patients with liver cancer, is to some extent the follow-up of our choice of following the guidelines that EASL and the American Association for Study of the Liver has developed in the last 20 years, putting radiology on the top of our criteria to make diagnosis of liver cancer in cirrhosis. This is a study done by the Lirad team, published in Radiology. You see here, everywhere in the world, very few patients will undergo a liver biopsy whenever there is a radiological clue for diagnosis of liver cancer in cirrhosis. The vast majority, in fact, who have wash in, wash out, they stop there. They don't do liver biopsy. So we are not providing material for science, developing science. Both societies, the Eastern societies, recommend, in fact, using multi-phase CT or multi-phase MRI because of similar performance characteristics. I must say that most specialists argued that MRI is superior to multi-phase CT in detecting small tumors, but this notwithstanding, the issue is something else. There is mounting evidence that intrahepatic cholangiocarcinoma, which is on the rise for a number of factors, also in the cohort of patients undergoing surveillance, patients with cirrhosis, may share similar enhancement patterns at MRI or CT scan as HCC. Therefore, there is a risk of misclassification of HCC with intrahepatic cholangiocarcinoma. This has been clearly shown in the domain of hepatitis B in Korea, and also in Milano, in our hospital, in the domain particularly of hepatitis C. And this is an additional reason why I think we should think to expand a little bit our attitude to do liver biopsies in the domain of liver cancer. Currently, liver biopsy after radiological diagnosis is basically done for patients undergoing liver transplantation, and occasionally resection, not for the bulk of the patients undergoing radiofrequency, so we need that. And to finish exactly what I have alluded before, that I did not resist the temptation to make publicity to our foundation. The foundation, of course, was created with a number of missions. One mission is a science, and we decide to back, to sustain the efforts of the European centers that are involved in regenerative medicine, because the ultimate goal would be to having a bioengineered liver, putting together the expertise of people who work in the hepatocytes, in the Kupfer, in the biliary tree here and there, and that are currently led by Professor Massimo Pinzani in London. And if you wish to know more about this, you might read the editorial that Professor Carson and myself wrote, and is online in the Journal of Hepatology, that explains exactly what we are aiming to with the bioengineered liver story and the regenerative medicine in Europe. I thank you for your attention.
Thank you, Massimo. Thank you very much. This is a modest but a very friendly award I will give you.
Thank you.
Please. Thank you.
Okay,
The
thank
PHC 2019.
Take a picture. No,
yes.
He wants to take a picture with you.
Okay. Yes. We'll go there.
Here?
Yes. Here.
Yeah.